Well, I feel like saying good morning to you all because I got up at 5:30 today, but it's 6:30 now. Good evening to you in sunny, wonderful New Zealand. You are so lucky to be practicing in such a beautiful part of the world. Right, so I'm going to try and position the topical immune modulators in my management of atopic dermatitis, but I've got a bit to go through before I get to that. I don't think there's any risk of any conflict of interest with tonight's talk, but I've done work for a number of companies. The rule I have is usually I don't accept a sponsored talk by a drug company unless I've already made my mind up that I particularly like their product and would prescribe it and recommend it anyway. But I don't think any of those companies there are involved here in the UK. So Tacrolimus ointment in New Zealand known as Zematop, and forgive me if I happen to call it Protopic, that's the British name, but it's Zematop, is licensed from the age of 2 years for moderate to severe atopic eczema. And the licensing specifically says where you can't use topical steroids for some reason. So, for example, on very thin skin, or the patients run into a problem with them, or they're otherwise contraindicated. And in New Zealand, it's actually funded under a special authority at Pharmac at this list price. But they specifically in your licensing in New Zealand say for initiation by a dermatologist or pediatrician. And furthermore, you're only licensing in New Zealand the 0.1%, which I'll come on to, which is the adult dose from 16 years old. So although Tacrolimus is licensed in the UK from 2 years, in New Zealand you can only use it from 16 because you only have the stronger preparation available. In the UK, we also have on the NHS Pimecrolimus cream, which is another topical immune modulator, which has a very similar license, but it's for mild to moderate atopic eczema. In New Zealand, I believe that's currently only available if you prescribe it privately, and there are the restrictions for either Tacrolimus or Pimecrolimus on it being initiated by a specialist on there. You can prescribe it if you wish without their specialist involvement. So that's just a limitation for you being able to prescribe it. These both became available on the general market and became available in the UK in about 2001. And about 3 years later, NICE came out with their thoughts on it. I imagine you've all heard of NICE. It's I call it the National Institute of Cost Effectiveness, because frankly, their decisions are made on cost, I think, far too strongly. But they like to think of themselves as the National Institute of Clinical and Health Excellence. I would love to have a National Institute of Clinical Health Excellence. I think that would be transformative for healthcare. But I see them as a National Institute of Cost Effectiveness. And back in the 2004, when they came out with their guidance, which hasn't been updated, as far as I know, they'd only been available for a few years. So our experience was very limited. There were still some theoretical concerns about some potentially serious side effects, which I'll be going through. And these are massively more expensive than topical steroids. And so it came as no big surprise that they gave a bit of a thumbs down to topical immune modulators, not driven by clinical and health excellence, but driven by those particular concerns. So I'm going to be talking a bit about the pathophysiology of atopic dermatitis, because that very definitely fits in nicely into why we should be thinking about these products. I'm going to be thinking about what's caused atopic dermatitis to become so much more common during my lifetime. And I'm then going to be going into some detail because these things that cause it are affecting the skin barrier. So what do we mean by the skin barrier and how is that made? And then I'm going to go through topical steroids, which are the main thing we normally use to manage eczema that isn't being controlled by other measures, and then into their problems as well. And then I'm going to talk to you about my thoughts on topical immune modulators. So I will get onto them, but it's towards the end. So what is the pathophysiology of atopic eczema or dermatitis? Well, this isn't really fully understood. There are undoubtedly genetic, immunological, and important environmental factors that between them result in some damage to the skin barrier. When the skin barrier is weakened, water escapes from the skin, and at the same time, allergens and pathogens can penetrate the skin. And in an individual who's genetically set up to have atopic disease, eczema, they have a hyperimmune and abnormal response. And that abnormal response causes inflammation. And that causes itch. And if you damage the skin by scratching it, you increase the inflammation and you actually increase the itch. So you've got an abnormal immune process going on because of the genetic factors, driven by things like allergens and pathogens penetrating the skin. And they penetrated in the first place because the skin barrier is broken, but then the whole vicious cycle starts and that damages the skin barrier even further. And rather perversely, once the skin becomes inflamed, the processes that enable, not only through scratching, damaging the skin barrier further, but this processes enable the skin to repair itself and make a normal skin barrier are also compromised. So the whole thing just goes out of control. So I'm sure you're very aware, atopic dermatitis is one of the most common chronic diseases that we encounter nowadays, affecting up to, I think I've seen figures of actually up to over 20% of children, almost 1 in 4 infants at preschool age. It drops down to about 6% at school age, but it's still affecting about 7 to 10% of adults. And interestingly, although we think of it being a disease of little children, because you have so many more years as an adult, there are many, many more adults walking around with life-constraining eczema than there are little children, and they've learned to manage it on the whole. But there are many more adults in the population with eczema than there are children, although the actual incidence, or sorry, the prevalence at different age groups is quite different. It's a very common disease. And I cannot think of any other inflammatory disease, not just skin disease or any other inflammatory disease, that's increased in prevalence so dramatically in my lifetime. If you look at a graph, it's a terrifying graph showing this rapid increase from around 1 child in 40, or certainly less than 1 in 20, just after the war, to now these levels of over 20%. It's plateaued in most first world countries at that sort of epidemic level. So what on earth has driven that? Well, we'll come on to that. I believe it is atopic dermatitis set up by skin barrier problems and that genetic disturbance that allows allergens to get in. And amongst the interleukins it releases is one called thymic stromal lymphopoietin, or IL-7. It's a relatively small molecule that can switch T1s to T2 lymphocytes, and it can travel around the body and go to the lungs where it drives eczema. It can go to the gut where it drives food allergies, and it can go to the nose where it causes rhinitis and it causes in the gullet eosinophilic esophagitis. I genuinely believe, I think it's that eczema opens the door to this disturbance in the immune pathway that then starts to drive what we now call the atopic march. And once you start making T2s, which are atopic and drive allergic responses, you inhibit the production of T1s, which are a more healthy response to an immune trigger. And if you produce T1s, you inhibit the production of T2s. So once you disturb that balance, you set up the atopic way of responding in the body. So it's a vicious cycle again there. So what's driven this alarming increase in the prevalence? What's changed in those 70 years? Well, I don't think it's fast food, and I don't think it's televisions. But the two things I think it could be are, one, antibiotics. We weren't using antibiotics before the Second World War. They're something that's been used in my lifetime. And I've got lectures galore on how to manage things like acne and rosacea and the like without using antibiotics. I'm ardently anti-antibiotics unless my patient has Lyme disease or an STI or urine infection or is ill. They can seriously disturb the skin microbiome. And we know that that is deranged in atopic dermatitis. Look at this. Up to 100% of patients with atopic dermatitis are colonized by a pathogenic Staphylococcus staph aureus, where it's only up to about 1/5 in non-atopic individuals. there's a dramatic loss of the normal microbiome diversity in atopic dermatitis, and that will be driven and aggravated by the use of antibiotics. And we know that the colonization by Staph aureus is directly linked to the disease severity. So antibiotics can drive that, and they can really disturb that microbiome. A recent paper that's just come out in the last few weeks has shown that if you give a neonate an antibiotic, they have an odds ratio of getting 1.5 times greater of getting atopic dermatitis. And in the first 6 months, the same sort of odds ratios, but they can also now show it for asthma as well. So give antibiotics, you are potentially switching things unfavorably for that individual for life. I think we should give really careful thought to using antibiotics. The other thing that I think could be driving it is our modern day, and I use this word fetish, with washing and detergents. Prior to the Second World War, people did not wash. It was unnatural to wash. Detergents are designed to remove oils and grease. Well, eczema is a dry skin condition. You need those oils, you need that grease. Yes, sweat and dirt get trapped in that grease. But if you remove that, you are making the skin barrier markedly more vulnerable, and I'll come back to this. Furthermore, all detergents are alkalis. And I'm going to talk about the acid mantle. The skin has a beautifully developed acid surface, which is there for a reason. If you put a detergent on, you're destroying that. And yes, there are synthetic detergents which are less alkaline, but they're still alkaline. And you do not want to put alkalis on the skin. Talking about washing, Queen Elizabeth I apparently only washed with soaps and in a bath 4 times a year. Bathing did not happen. And that's, I think our ancestors probably stank, but they didn't wash. And our skin has not evolved to cope with today's barrage of detergents. Had it done so, we'd have fish scales, I can assure you. But you look at these figures here. In the 1950s, only 1 in 7 households in the UK had an indoor loo, yet alone washing facilities. By 1971, almost 90% of households had an indoor bath and shower. And by 83, 97%. Today, virtually everyone is showering or bathing in a bath at least daily, sometimes more than that. And they're often in that bath or that shower for 15+ minutes using detergents. Detergents are designed to remove that surface oily layer, and dirt and sweat are trapped in that, and that's how you remove them. And they raise the pH from the normal surface pH, which is significantly acid, more like 5.6 actually, to over pH 8. And if you raise the pH that much, you will double the activity of the proteases that break down the corneal desmosomes that hold the skin cells together. It's a disaster for the skin barrier using detergents on the skin. But we have a modern lifestyle where we live in these very dry environments. Our ancestors used to have mud walls and mud floors and no carpets. Today, we're concerned about worry about mold and things like that. So we have dry central heating, dry air conditioning. We use excess washing to take the moisture out of the skin, and even some medications can make things worse. A whole lifestyle is designed around a very, very dry environment, which is a disaster for dry skin conditions. I've been mentioning the skin barrier, and I would like just to take you through what we mean in dermatology by the skin barrier, and why it is so critical to understand that in the context of topical immune modulators. So the skin barrier. The skin barrier is a very, very thin top layer of the epidermis. The epidermis is actually down to about 30 nanometers on the eyelid. It's already very thin. It's 600 and something nanometers on the heel, but it's only 30 on the eyelid. And on the eyelid, the thickness of the epidermis, the stratum corneum, the top layer, is 1/10 as thick as that is of a piece of paper. It is incredibly thin. But we depend on this very, very thin layer to protect us from that dry world that we live in. And when it's compromised, all hell lets loose. You don't need a skin barrier when you're in the womb because you're in this watery environment and it's sterile. So there is a skin barrier, but it's very, very weak. When you're born, if you're born at term, you're covered in this stuff called vernix caseosa. And if you look at the consistency of that, that's almost identical to the fatty composition of the skin barrier. I always see people wanting to wipe that off. It's the best emollient in the world, and it's there for a reason. It's to protect the skin while it takes a few hours for that skin barrier to develop. It's not there right away. It needs to be switched on. And if it's not switched on, the baby will die within a few hours through water loss. Absolutely critical that you adapt to creating that the moment you come out of the womb. It's one of the major adaptations at birth. We measure what's called transepidermal water loss, or TEWL, and it's significantly greater in babies. Really worrying. But we also know, though, that if an infant has a greater TEWL, as measured, greater water loss, a weaker barrier, they are significantly more likely to develop atopic dermatitis or food allergies at 2 years. So this is really important, what's going on there. Now, the skin barrier, as I say, is this top layer of the skin. It's those cells up there, the very top layer of the epidermis. And these cells have lost their nuclei and are flattened or stratified. You know, I even hear dermatologists saying the stratum corneum is composed of dead cells waiting to fall off. These cells are not dead. These cells have an oxygen demand, they're living, they're very important. Yes, they're terminal, they don't have nuclei, but they're not dead. I don't think of my skin as having dead skin on it, any more than I think about those red cells that go around my circulation being dead cells. They haven't got nuclei, but they've got an oxygen demand, and those are living cells. So what's going on? How do we make this? Well, the top layer of the epidermis is there up at the top. You can see how the pH changes from a neutral pH just below to the acid pH on the surface. That's the stratum corneum. Just below that, we have the stratum granulosum, so-called because granules start developing and are very important. Below that, the stratum spinosum with its dendritic cells, tissue macrophages and Langerhans cells and things like that. And then the stem cells, the basal cells that sit on the basement membrane and anchor the epidermis onto the dermis or onto the basement membrane. Now, there are two types of granules in the stratum granulosa, the keratohyalin granules and the laminar granules. The keratohyalin granules produce two very, very important products. One are these rods, these keratin tonofilaments, a little bit like reinforced concrete rods. They're long rods of protein. They also produce a large, huge protein called profilaggrin, which breaks down into filagrin, filament aggregating protein, which aggregates those tonofilaments. And it aggregates them into a lattice. When that lattice gets to a critical size, the lattice collapses naturally on itself, rather like putting an ironing board away. Here's the filagrin protein coming from the exon 1 Q21, the exon 3 part of the chromosome 121. And that epidermal differentiation complex is involved in the production of all these features of the skin barrier. So it's the filagrin aggregates those tonofilaments into a lattice, collapses the lattice, which changes the shape of the cell from being cuboidal to stratified squamous epithelium. And once it's done that, the filagrin breaks down into a whole load of very small molecules, amino acids, urocanic acids, peroxyl carboxylic acids, urocanic acids, and I've said that one, lactic acids, and so on. Having changed the shape of the cell, this cell now has a very flattened shape with a very large surface area and a geographic shape which allows it to interlock with the neighboring cells. Sorry, excuse me. But with this huge surface area, gives enormous scope for linking between the cells with bonds to make the cells hold together nice and tight. Those breakdown products of filagrin are all known as natural moisturizing factors. They're all intensely hygroscopic and they draw moisture up from the dermis into that cell puffing it up full of water, pushing it up tight against its neighbors, and holding that water in that epidermocyte. This is the constitution of those, the natural constitution of those natural moisturizing factors. And they include things like hyaluronic acid, a sugar. One molecule of hyaluronic acid, which is a huge molecule, can hold over 1,000 molecules of water. These are really powerful hygroscopic agents, and they're there largely to draw moisture into the cell and hold it there, to hydrate that stratum corneum. If you note, they're all acids: lactic acid, urocanic acid, broadline carboxylic acid, amino acids. But those, along with the laminar lipids, which break down into free fatty acids, and sweat, which is acid, create the acid mantle and drop that pH from 7 down to 5.6 or so. Now, that acid environment is critical. So I've already mentioned it controls the activity of the proteases. And those proteases are there that being produced to try and peel off the skin in a very coordinated fashion, breaking off the corneal desmosomes carefully at the top, but you don't want to have that out of control. And I've already said that if you increase the pH, you increase the activity of these things like kallikrein 7, one of the proteases that breaks down corneal desmosomes. It also has natural antimicrobial effects. It favors the adhesion of healthy bacteria like Staph albus and kills Staph aureus. So we know that that acid mantle is doing more than just controlling the protease activity. It's really important. The laminar granules, which first appear in the upper stratum spinosum, produce ceramides and many other fatty molecules. Cera comes from the Latin meaning wax-like. There are over 10 of these ceramide fractions. And these actually break down into free fatty acids as well, which have very long non-polar tails and polar heads. And when you've got non-polar tails in a water environment, they orientate themselves away from the water. So the tails begin to point towards each other like that, with the heads pointing out towards the water. So it naturally produces a bilayer. The spike proteins of COVID are sitting on the lipid lamellar bilayer, which is the envelope of that virus. There are many different lipid lamellar bilayers produced in this fashion. And it's made up of all these ceramides, cholesterol esters, and long-chain free fatty acids that create this lipid lamellar bilayer, which oozes out of the cells and forms an oily material between the corneocytes. So this is the cement between the cells. It's a fatty, oily cement that seals the gaps between the cells, but also confers some flexibility to the epidermis. The lamellar bodies also produce a protein called corneodesmosin, an enzyme called corneodesmosin, which converts the weak bonds deeper in the skin, the desmosomes, into the really powerful corneodesmosomes. And these then lock the corneocytes together, resisting shearing forces. And you'll notice these pinky red corneodesmosomes, also they penetrate through the cell membrane, and then they link up with the now freed up keratin tonofilaments. So they've got even better anchorage inside the cell. So you've got this phenomenal bond holding the cells together, this corneodesmosome, linking into those keratin rods. Finally, sebaceous glands produce a grease that oozes out along the sides of the hair follicle, out onto the surface of the skin, and they get a nice oily surface that prevents the last bit of water escaping from that surface. Deeper down in the skin, you've got in the stratum spinosum, where you've got the immune cells, which anything that gets through those top layers is picked up by those and presented to the immune system. But down in the stratum spinosum, we're making over 4,000 natural antibiotics, antimicrobial peptides. And these actually have incredibly important roles. I won't go through that, but there's some very interesting, you can look at this slide later if you want. They control the activity of a number of things. When they're not working, there's a problem there. So we have a skin that's nice and healthy, preventing water escaping. That small blue arrow at the top shows little water escaping. The cells have changed shape. You've got filaggrin breaking down and stuffing the cells full of water. And you've got a nice lipid lamella intact envelope around the cells, healthy corneocytes full of water, and the proteases are breaking down the cornea desmosomes in a beautifully controlled fashion. And in that situation, allergens don't get through. You don't stimulate the Th2 lymphocytes with your thymic stromal lymphoprotein, the IL-7, and everything's in a lovely, healthy state of balance. Not bad, eh? For dead cells waiting to fall off. I think it's remarkable that that's all going on up there, and we have no idea this is all happening. It's incredible, isn't it? But once the skin becomes inflamed, granular activity gets switched off, and that reduces the production of filaggrin and reduces the lipid lamella envelope production. You've got a broken skin. It's all damaged. Nothing's working properly. Not producing the things. You've got dehydrated corneocytes pulling away from each other. You haven't got the natural moisturizing factor production. You haven't got the acid mantle controlling protease function. You've got a defective lipid lamella envelope. It's not conferring that flexibility. And you've got increased protease activity, and you've got increased bacteria around the place. Everything gets in, you stimulate the Th2s, you scratch the skin further, you've got a vicious cycle. And you've got everything going wrong, and you've got this cascade releasing these really nasty inflammatory interleukins that are important in eczema. We have biologicals that switch those two interleukins off, IL-4 and 13. I tell my patients with eczema, your eczema will not settle unless all detergents are stopped. That's soaps, shower gels, shampoos on the skin, bubble bath, all detergents. And I go through in detail how they should manage their life in the way that our ancestors did without using soap, using emollients. Emollients are essential. They're buffered to the acid pH. They re-grease the skin rather than degrease it. So you should wash with an emollient, and you should leave a quality leave-on emollient on afterwards. And it's a perfect vehicle for bringing many other products onto the skin that can do wonders. But I'm not going to go through emollients here. I've got talks and talks on emollients. Topical steroids have been around longer than me. They first started putting some hydrocortisone into a cream, an ointment rather, with just hydrocortisone, and they called it compound F. And they thought we had the cure for eczema. And I think we probably did. It's an amazing work by Victor Witten and Salzberger. And they really work. They're powerfully anti-inflammatory. Excuse me. They don't smell excuse me, or stain, and they don't normally sting or anything. And they are remarkably inexpensive today. And they are key to the management of inflammatory skin conditions. I think it'd be almost impossible to practice dermatology and manage these sorts of conditions like lichen planus and discoid lupus and so on, even acute lipodermatosclerosis, without using a potent topical steroid. They are wonder drugs in those conditions. So how should we use them? Well, very quickly, I think always have an interval between using a topical steroid and any emollient. Otherwise, you just dilute the emollient. I generally say put the emollient on first, cover all the skin, because the whole skin's got an abnormal microbiome, the whole skin's dry, the whole skin's abnormal, and then just dot the topical steroid on top of that 30 minutes later where you want to use the steroid. Start potent, get control, get it under control, switch all those inflammatory processes off as best you can, and then reduce it once things are under control. But don't stop suddenly, always taper down. And I'd prefer to taper down the frequency of using it, so they just have one prescription for the steroid, and then they can use that initially once a day, and then alternate days, and then perhaps drop down to weekend therapy, where they use it for 2 consecutive nights a week, for say Saturday and Sunday nights, for a further 3 or 4 weeks. So I prefer to reduce the frequency rather than confusing patients by having different strengths, but they might need different strengths on different parts of the body. So you can taper down from the very potent ones, excuse me, things like clobetasol, that's Dermavate in the UK, to Betnavate or Betnazole and Elicon, mometazone, and then down to the weaker ones like 1% hydrocortisone. Just be careful, there's some hydrocortisone esters that are very potent. Hydrocortisone acetate is mild, but hydrocortisone butyrate is as potent as, well, it's more potent than betamate. It's a very, very super potent topical steroid. So if you just say hydrocortisone, you need to qualify by saying hydrocortisone acetate. I would urge you only ever to prescribe topical steroids as ointments. The one exception might be really moist flexural eczema where the ointment would just slip off. But I only ever prescribe them as ointments. They have a very low water content and so therefore don't need preservatives. And many people using steroids over a long period of time become sensitized to the preservatives in the creams. Furthermore, the ointment tends to stay where you put it, and it provides natural occlusion, increasing its effectiveness. It increases its potency as well, actually. It prevents water loss and enhances the skin barrier, and they just generally stay where you put them. So I think that's fine. And I say you only ever need to use a topical steroid once a day. I see very little advantage putting it on more than once a day. You just get more side effects. So using it last thing at night at bedtime, it's not the end of the world to have greasy skin at that point in time. It's not like you're using a computer or trying to shake hands and things. So I think that just using it once a day at bedtime works very well, and then you can use an ointment with less disturbance to their lifestyle. And make sure you prescribe enough to achieve the outcome. And talk to your patient, therefore, about a fingertip unit, which is one intelligent thing in medicine, is that all creams and ointments come with half a centimeter nozzle. It's really, really helpful. So it means that you can squeeze out and you know exactly how much you're getting, about half a gram. And that will cover the area of skin of 2 palms. So you can work out roughly how much they need. They're using it once a day. So where's the problem with topical steroids? They work, they're clean, they're fantastic. Well, often patients are told to use them sparingly and therefore and not to put them on broken skin. But hang on, eczema is broken skin. And then don't use on thin skin areas such as the face. And often doctors collude with this misinformation. And as a consequence, patients don't use them. This patient brought their tube of ointment to see me. They'd been prescribed this 6 months ago. I was talking to somebody last night who had been given 100 grams of Humavate 18 months ago, and he still says, I've got plenty left. He's not using it. He doesn't understand how much to use. He hasn't been told about fingertip units. So should we be concerned about them like these patients? Or should we just continually badger them and say, for goodness sake, use a fingertip unit, use it as I say, just use them? Well, when eczema flares, inflammation is the dominant problem. And in that situation, they are highly effective. And the average patient with moderate atopic dermatitis has about 9 flares a year, each flare needing treatment probably for about a month. If their eczema is more severe, they have 11 flares a year on average. Well, that means that they're probably using a topical steroid continuously. And certainly they're severe. They don't manage to get off the topical steroid. They might get down to weekend therapy occasionally, but that's about it. So they're now on it's a chronic relapsing disease. They're on continuous topical steroids. Topical steroids are not licensed for continuous use. They're in fact only licensed for short courses in the UK for 2 weeks. Yes, we use them for much longer, but that's off license. And they're not suitable for flare prevention. They're not licensed for flare prevention. So we are using steroids for eczema effectively off license. Steroids raise the skin pH. Hang on, that's a disaster. That activates the proteases, doubling that activity, and you lose those beneficial effects of the pH on the skin microbiome. I don't want that. They degranulate the stratum granulosa. Hold on, we need that to make the keratohyalin rods and the keratohyalin, the keratin tonofilaments and the profilaggrin and the lipid lamellar envelope. And without that, your skin barrier is already becoming compromised. They break down proteins. The cornea desmosome bonds are protein. So not a big surprise. that after 15 months of this continuous use of topical steroids, you've halved the thickness of the epidermis. A thinner epidermis is a weaker barrier. These are all the more disastrous on the thin skin areas around the eyelids, fronts of the elbows, backs of the knees. But hang on, that's where you get eczema. And the other thing is topical steroids are small molecules. They're all under 500 Daltons. Anything under 500 Daltons penetrates down to the dermis. Topical steroids reduce the structural protein collagen in the skin. And without that, our blood vessels are unsupported and the skin is unsupported. You get striae and you get ecchymoses and you start seeing blood vessels through the skin. And I've seen those develop within a fortnight of using something like Elicon, mometasone. So you are destroying the ground substance that supports the deeper layers of the skin. And the skin starts getting a papery thin, translucent appearance and shears and tears and becomes very much weaker. And then they can cause cataracts and glaucoma, especially when you use them close to the eye. Topical steroids are powerful anti-inflammatory drugs. They're immune suppressing. And that immune suppression is not targeted. And so you run into problems when you've got a fungus on the skin, and you can produce tinea incognito by allowing the fungus, rather than staying on the top layer of the epidermis, to drive down deeper into the dermis, where it forms bumps and an abnormal appearance. And it looks different. It's less scaly, but it's because your immune system's been compromised by the steroid. They can cause periorificial dermatitis, which is, I've never seen that in someone who hasn't used a topical steroid, often inadvertently, because it's been hidden in another combination product, or they've been treating their child's skin and the residue's been left on the skin, or from inhaled steroids. And they can cause hypopigmentation, which is quite disfiguring, particularly in dark skin. Because they're easily absorbed, particularly in children, they've been shown that they can actually cause suppression of the pituitary adrenal axis, and that can be quite dangerous. So that's a problem there. And absorption is affected by how thin the skin is. If you look at very thin skin areas, up to 30% of the topical steroid penetrates through and gets into the bloodstream. So these can have significant effects on the body if you're using potent steroids in these areas. You can get contact allergic reactions, not just to the preservatives, but even to the steroid molecules, well described to betamethasone, so betamethasone, and to hydrocortisone. And the potency of a topical steroid is measured not by those features, but by how much vasoconstriction it causes and how long that lasts. Well, some individuals get rebound vasodilatation, and that can be really horrible. And it's known as the topical steroid withdrawal syndrome or red skin syndrome. And this can be absolutely ghastly. It's not just uncontrolled eczema. This is a condition that's brought on by topical steroids, and if you go on using them, it goes from terrible to unbearable. In this condition, the skin can be so inflamed they can't even put water on their face, yet alone emollients. It's disastrous. Well, we had no alternatives until the beginning of this century, but we do now. Topical immunoglobulins have been around for 25 years or so, and they have transformed my practice. Yes, we also have other new ones coming along, like the phosphodiesterase inhibitor Premilast and JAK inhibitors, which I think are incredibly topical as well as systemic, incredibly exciting. But I'm going to be focusing on the topical immune modulators. Secondary care want to keep these as theirs. They don't want us to use them because they're safe, they're effective, and they're licensed for long-term use. They preserve the skin barrier, they preserve the acid mantle, and they provide targeted immune modulation. They want to keep them there, but I think that we're denying the population these. They're licensed for mild to moderate eczema in children over 2. Actually, I've seen advertisements recently saying that Elidel, that's Pimecrolimus, is suitable from 3 months, and I've certainly been using them both from 3 months of age in the UK for 25 years almost. And Elidel, or Pimecrolimus, is equivalent to Umivate, that's clobetazone butyrate. So it's a moderately potent topical steroid. It's more than mild. In the UK, in New Zealand, I gather you haven't got it except for on private prescription. Topical Tacrolimus, Zematop, The name Tacrolimus comes from T from tuxuco, because it was first isolated from this bacterium called Streptomycin tuxibonensis near Mount Tsukuba in Japan. Acrol is a macrolide derivative, so you shouldn't give it to somebody who's got a macrolide sensitivity. And imus, given systemically, it's immune suppressing. And this is licensed for moderate to severe atopic dermatitis in adults over 16. And the 0.1% ointment is equivalent in strength to betamethasone. It's as potent as a potent topical steroid. In the UK, we have an ointment that's a third the strength, about 0.03%, and that's licensed from 2 years. But again, I've been using it under 2 years off license for a long, long time without problem. So it's equivalent in potency to betamethasone and mometazone. So it's pretty powerful stuff. And it's even stronger than fluticasone. So it's a powerful anti-inflammatory. And as I said, it preserves the acid mantle. It will regranulate the stratum granulosa that's been degranulated by the steroids, enabling you to develop that skin barrier. They do not cause any loss of the epidermal cells, so particularly ideal on thin skin areas. And furthermore, it's been shown to increase procollagen 3 levels in the dermis, so supports that area. It preserves the skin barrier and recovers the dermis. They're ideal for thin skin areas. So around the eye, fronts of the elbows, the very areas where atopic dermatitis is the biggest problem, because that's where the skin barrier is at its most vulnerable. This is a little lad, age 2, who came to see me with eczema around his eyes, and I went straight in with Protopic. I think he had used some Humavate, and his mum was worried about all sorts of problems. Within 3 weeks, completely transformed. It's controlled. That was with the 0.03%. I know you haven't got that in your country yet. Now, these are not immune suppressing when used topically. These are immune modulating. They're switching off that abnormal, genetically driven immune pathway and preventing that cell from producing those nasty pro-inflammatory cytokines like IL-4 and 13. It's blocking those pathways and preventing the cell from reacting to those allergens and pathogens in this abnormal way. It's just switching off an abnormal pathway. It's not immune suppressing like topical steroids. So they provide targeted immune modulation, sorry, not nodulation, modulation, not global immune suppression, which is what a steroid is doing. So they maintain the skin barrier and they switch off the abnormal immune system dysfunction. And so they are doing both elements of what you want in atopic dermatitis. They treat both aspects of that. They have a dramatic effect on itch, relieving itch rapidly and maintaining that when you continue with it, just using Tacrolimus on its own. And the emollient has some effect, but these are dramatically more powerful at relieving itch, which for the vast majority of patients with atopic dermatitis, that's the thing that keeps them awake at night. That's the thing that distresses them. Yes, their face and their hands distress them, and loads of others, the shedding of skin distresses them. But that is a major, major problem, the itch. Actually, quickly on that point, antihistamines don't help the itch of eczema. The itch of eczema is not mediated by histamine. So using antihistamines is pointless. They might cause you to be drowsy if you use an old-fashioned sedating one. That's why we don't recommend using the non-sedating ones, because they don't work. Having said that, fexofenadine has been shown to decrease the level of IL-31, which is the interleukin that does drive eczema. But don't use antihistamines for the itch and eczema. They just cause. I've used the sedating ones. They hang around for hours, 24 hours plus. So the individual will be drowsy the next day, affecting driving and education. This little boy, this is definitely off license. He was 9 months old. His parents were exhausted though by him just not sleeping because of itch. He was developing food allergies. Everything was just going wrong in their household. They've been using clobetasone, that's Humavate strength, but they were reluctant to continue. It just wasn't holding it, and they were using that properly. So after a lot of discussion, I gave him some 0.03% Protopic, and within a couple of weeks, they said he was a different baby. He hadn't been like this all his life, and it completely transformed his eczema. They couldn't believe it, and his eczema has remained at bay. The topical immune modulators are huge. They're both over 8. I think Tacrolimus is about 700 and something Daltons, and Pimecrolimus is 840. Well, anything over 500 Daltons barely penetrates the epidermis. So they both stick on the top of the skin and stay there. Most topical steroids are around about 400 Daltons. So there's no significant systemic immune suppression from these at all. Furthermore, Pimecrolimus in particular has an extraordinary affinity for the skin. Even if you give it after oral dosing, it concentrates onto the skin for some reason. And it just doesn't get through. Unlike the steroids, which you can see they are penetrating quite dramatically, Pimecrolimus just doesn't penetrate through the skin. Now, steroids, as I've said, are not intended for long-term use or flare prevention, yet we use them inevitably because of the number of flares patients are getting. And a number of times I've seen people who've been seeing a doctor for their eczema. Every time they get an eczema flare, they're managed and managed quite well. But no one spends time talking to them about flare prevention, how to stop that happening again. It's so important. The topical immune modulators are actually licensed for long-term use and flare prevention. That's where they come in particularly. They aren't without their problems. Topical tacrolimus in particular, Zematop, can cause a sort of a warm, almost burning, stinging feeling when you first apply it, particularly if you're putting it onto very inflamed skin. So sometimes I overlap it with using a steroid as well. A steroid perhaps once a day and the tacrolimus just once a day initially, or even less than that. Yes, if you apply it direct from the fridge when it's cold, that makes less problem with stinging. But I do suggest people start very gently. The skin's very inflamed. I don't just say put it on twice a day. I say perhaps put it on once and then leave it for a few days. So you're actually maybe using it just twice a week initially, and then build up to alternate days, and then gradually build up to using it once a day, and accept the fact that your skin will sting for up to an hour or so after you've applied it. But it will ease off. And then as you continue using it, within about a fortnight at most, you'll find that you can put it on without it stinging. The skin is no longer so inflamed. And then you can start using it twice a day, which is the normal dose. But do talk to your patient about building up gradually. Don't go straight in, and warn them it will cause some stinging. Being an ointment, Tacrolimus needs to be taken at least 2 hours away, or used rather 2 hours away from any emollient. Otherwise, you're just diluting it. Pimecrolimus cream, if you happen to prescribe that, being a cream, you can use it within half an hour of an emollient. But with an ointment, you want to split them apart by at least 2 hours so that you're not having that diluting effect. And as I've already mentioned, you could overlap with a topical corticosteroid for the first week or two, partly to try to alleviate that stinging that the Tacrolimus, the Zematop, can cause. And then build up gradually to the normal therapeutic dose, which is twice a day until the eczema is controlled, which is usually 2 to 3 weeks. It's that sort of length of time before the skin's looking much more normal, with a nice, healthy, normal skin barrier. And then once it's under control, you can drop down to maintenance therapy, which is where you just use it twice a week on non-consecutive nights. So I suggest perhaps a Wednesday night and a Sunday night, or a Monday night and a Thursday night. Just using it once a day at bedtime, twice a week. And that's a trivial dose, costing virtually nothing and keeping the number of flares right down. So they're just not having flares, not needing to come and see you, and not needing expensive treatments. It's a young woman who's having a terrible time, and she was a lady who'd brought that tube that she wasn't using. So I debated whether just to push it up, but it's round her eyes, and she was quite worried. She was a teacher. She was off work. She was highly distressed. It was beginning to damage her marriage, all sorts of problems. So I put her straight onto Protopic, and within a few weeks, her skin was back to normal. Her life was back to normal. She was back teaching. Everything was great. Well, in New Zealand, the state-funded product can be prescribed from primary care, but only after it's been recommended and initiated by a specialist, i.e. a dermatologist, a pediatrician, or ophthalmologist. I think that's an insult to you. I really do. I just don't see why we should be wasting their time and involving them with this product. You can prescribe it privately without any restrictions, but it's just a means of controlling the costs. The cost is what has imposed those restrictions on you. And yes, they are significantly more expensive than the steroid alternatives. I've got the prices there for you to look at. I think Elidel, which is Pimecrolimus in New Zealand, only available privately, is about the same price, but it's for a smaller tube. So they're quite significant costs. And I'm sure what the state is concerned about is unrestricted and uncontrolled overuse of these products. But I think we should be looking at eczema in a much more global fashion, much more holistic. Imagine the cost of eczema to society and the individual. For the patient, not sleeping, the whole household not sleeping because the baby's awake or the child's awake or even the adult's awake. It's using up a lot of your time because they keep coming back for flares. And that's using up your time and is costing them and everybody more money. Referral to secondary care is very expensive. It costs 5 or 6 times the cost of a tube of this stuff. And then there's all the time spent applying treatments that don't really work and have side effects and problems, all the time taken off work to go to appointments and drive there, interrupted educational work, and many more considerations. Eczema is expensive for society and very expensive for the individual. These costs are trivial in comparison to that. Other side effects, just to think about quickly, they can cause some photosensitivity. You need to be aware of that. So I would generally say when you're dropping down to using it just once a day, put it on at bedtime. But during that first initial time, maybe use some extra sunblock, be careful. Interestingly, some tacrolimus must get absorbed because some individuals, up to about 1 in 10, experience some flushing if they drink alcohol. So again, just warn the patient that their face might flush if they've used the tacrolimus somewhere else even. Just like steroids, it can cause a folliculitis. I wouldn't recommend them in pregnancy. And I'm sure you may have heard the concerns about T-cell lymphoma. There's no doubt that systemic tacrolimus used for transplant rejection, to prevent organ transplant rejection, is a powerful immunosuppressive and is associated with increased risk of both skin cancers and other cancers, notably lymphomas. It's very similar to cyclosporin, but much more effective. So there is a concern there. So we know that systemically tacrolimus matters. And this was raised by the FDA in America based on large animal models where the patient, the rat was covered from the tip of its nose to the tip of its tail continuously in these agents. But the levels of tacrolimus they managed to get up to are much higher than the levels. So they were looking at systemically as well. We cannot get those sorts of levels, anything like it, when it's used on the skin. You cannot get that level up through the skin. It's just not going to achieve that. So it's not going to act as an immune suppressive. And they've done enormous studies looking at this. Look at this one of over 950,000 patients, confirmed that topical immunomodulators were not associated with any increased risk. We do know that uncontrolled eczema is associated with a slightly increased risk of lymphoma. We know that topical steroids are associated with a slightly increased, just measurable, increased risk of lymphoma. And I suspect topical immune modulators will be in a very similar ballpark. Very minor, slight increase, but you're no worse than leaving the eczema untreated or using a topical steroid, is what I tell patients. So I think it's an ideal primary care agent. It also has some other fantastic off-license uses. I use it for facial psoriasis in particular. This is an example of facial psoriasis around the eyelid. I would not want to use any of the vitamin D analogs there. I wouldn't want to use steroids there. But topical tacrolimus, Zematop, would switch that off within a few weeks. Absolutely brilliant. I use it also for flexural psoriasis, another tricky area to manage. Unlike steroids, which drive peri-orificial dermatitis, topical immune modulators are great at treating that. So this is peri-orificial dermatitis, and I would go in with probably Elidel in this country, but you could use Protopic if you wanted. Probably a bit too strong for that. And that would almost certainly switch that off for you. Oral lichen planus is absolutely brilliant for And vitiligo, just a quick word on vitiligo. If you see somebody with recent onset vitiligo on the face, not elsewhere, interesting, so on head and neck, you've got vitiligo there and it's been there for less than 3 weeks, Protopic can cure that dramatically. If you leave it for longer than 3 weeks, it won't work so well. So don't wait to refer the patient to hospital. Don't delay getting them advice from a secondary care specialist. You can actually switch that off if you get going with it quickly, but you haven't got time. So it's an important take-home message. For facial vitiligo, off license, topical Tacrolimus will switch that off for you straight away. So yeah, topical steroids have been around for 70 years, and we know where we are with them. We're very familiar with their side effects and their benefits. And they don't stain, they don't smell, they're easy to apply on the whole, and they're cheap. So you can understand why our states are eager for us to continue using those. Would I use them? I might use them for a week or two, but I would want to use alternatives as much. I'd want to avoid using them as much as I can. They damage the skin barrier. They're not licensed for long-term use. And their anti-inflammatory effects are associated with this very broad spectrum immune suppression, which is the last thing you need. You do not need to suppress the immune system. The topical immune modulators, on the other hand, they preserve that critical skin barrier, and they provide this targeted immune modulation, switching off that abnormal pathway which you don't want. And they're ideal for the very areas where you get eczema, the thin skin areas around the eye. And they're licensed for prevention and long-term maintenance. You can go on using it for at least a year, at just twice a week, to prevent the eczema coming back. So I believe these are ideal primary care products. You should not tolerate those sort of restrictions on your prescribing for such an important group of drugs. And I think you do need to demand that you get both the Pimecrolimus cream and the 0.03%, so you can start treating down to 2 years of age. They've been used in Europe for over 20 years, and I can't see why you're so far behind. And these are licensed in the UK for any doctor who is competent with them to prescribe them. Well, frankly, in my book, that's all of you. You're all doctors, you're all managing eczema, you're all seeing patients with this. You should have access to these drugs. They've been around long enough now for us to know they're safe. I would say that Protopic, or in the UK's Protopic, Zematop, in your country, is one of the most dramatically amazing new topical treatments this century. The other two are Soolantra, or topical ivermectin for rosacea, and Enstellar for which is the foam form of Dovabet rather, for psoriasis. Those three have transformed the landscape of patients with skin conditions, but Protopic has been around the longest, and I think is perhaps the most amazing. And dermatologists would not want to practice without it. It's an amazing product. So on that, thank you very much indeed.
Thank you, George. That was a lot of good information, and I certainly jotted down some practical tips that I can take through to my clinic tomorrow, really. So that's awesome. I just wanted to highlight to the audience that this webinar is also sponsored by an educational grant from Douglas Pharmaceuticals, and the content was developed independently by Goodfellow Unit and by George. And so now we're going to get into some Q&A, and George, we've got some really good questions coming through. So do you know why it is that Tacrolimus is not licensed for use under 16 as opposed to Pimecrolimus?
It is a license, but not at that strength. So I haven't quite got the question. Pimecrolimus is licensed from 2 in children and adults. Protopic is licensed from the age of 2, but at the weaker strength, the 0.03%, and from 16 at the 0.1% in the UK. And I think the same in where you are. So
yeah, I was just checking on our formulary, George. It says that Tacrolimus is licensed 16 and above, and Pimecrolimus 1% is from, on our formulary, it says from age 3 months and above.
Right. Well, Pimecrolimus is much weaker. It's not licensed in the UK from 3 months, although we're told it's suitable from 3 months. It's very interesting. I didn't know that it was licensed from 3 months in New Zealand. That's fantastic. Certainly, I've been using it from 3 months without any hesitation. I guess it's down to the strength of the products. I have to give that some thought. Interesting question. Thank you.
The Tacrolimus 0.1%, is it possible to use it kind of off-label in younger people?
Yeah. If I had to, absolutely no reason why you shouldn't, as far as I know. I probably wouldn't use it right down to the age of 2. Generally speaking, I think the skin is thinner in children, so it takes less to control things on the whole. And I normally find the 0.03% will work. And I suppose what you could do is just use it close to an emollient and just dilute it a bit. And so you could sort of get a sort of a benefit that way. Yeah, I think I'd feel very sad trying to practice without having access to the 0.03%.
Yeah, there's some questions around whether the 0.1% tacrolimus can be compounded for use in children to a weaker
Yeah,
percentage.
I don't see why you couldn't try that. Yeah, I think that
Mhm.
sounds very. You would be held accountable for having altered its formulation a bit, but I can't see it doing any harm at all. Just use it a bit closer to an emollient.
What is the best order to apply the emollients and then the Pimecrolimus or Tacrolimus?
There is some, well, there's some research going on into the same question regarding with topical steroids, and I'm sure the same advice will carry on with the topical immune modulators. And so they're actually doing some research at the moment, putting one on first and then the other on second, and vice versa. My personal preference is I say just put the emollient on first, coat the whole skin in the emollient. The whole skin's abnormal, as I explained. Leave that for a while. The topical steroids, I usually say leave it for at least half an hour. But with topical tacrolimus, I say Zematop, I'd say leave it for 2 hours. And then you just dot that on the areas where you want to be treating.
Okay. Is there any evidence for use in rosacea, George?
Not that I know of, no. Never heard its use in rosacea. Interesting question. I use, well, if it's papulopustular rosacea, I use Sulantra, which is amazing. And I don't think it would have any effect on the erythrotelangiectatic patterns of rosacea. No, I've never heard of it being used for that. Interesting
Okay.
question, though. Mm.
There's another question around use in Pompholyx.
Yeah, Pimecrolimus is basically just a form of eczema where the epidermis is much thicker, and so eczema means out boil, and in eczema, ek means out of, as in out of place, ectopic. Zema means boil in Greek, and you're getting these little bubbles of fluid, or the spongiosis we see under the microscope in the epidermis. These little bubbles that come through the skin, rupture to the surface, ooze out some fluid, and split the skin and make it sore and itchy. But in areas where the skin's very thick, like the palms and the soles, you get the bubbles can't come out, and so they become collected into large bulli, and so that's Pompholyx. So essentially, Pompholyx is usually a form of eczema. And yeah, it'll have more difficulty penetrating through that very thick epidermis. But it would penetrate a bit and certainly be very useful. Yeah. A steroid will penetrate more easily in that situation, so I'd be more inclined to use a super potent topical steroid because of the thickness of the epidermis.
Thank you, George. And you mentioned that the Pimecrolimus and Tacrolimus can be used for maintenance treatment. Now, if that's working well for someone, is there any time that they should kind of have off, or like a holiday period, a break after a certain
Yeah,
period of time with maintenance?
it comes a bit, if you've got good control and you've really controlled the eczema and you're getting no flares, it's quite hard to go on persuading patients to put a treatment onto their normal skin twice a week indefinitely. So it gets to the point where you start saying, fair enough, yeah, why don't we stop and see what happens? And they'll probably get a flare back fairly soon, and then you set off all over again, building up to using it twice a day, and then for 2 or 3 weeks, and then drop down. Certainly, I've used it for up to a year, and I think patients who've had a problem are more than happy to have a year in remission without any problems, and then if things are still good. By that time, I've had a lot of chats with them about their lifestyle and their washing, and they're changing all that. And those combinations can often result in them having no significant problems with eczema for years on end.
Wonderful.
But I agree, probably up to about a year, and then thereafter, I think not so much have a holiday from the treatment, but really, why treat the normal skin?
Okay. Now, in New Zealand, our special authority for both of these is that they have to have eczema and also at least one contraindication to topical steroids, George. Now, overseas, is there an argument for using these kind of first line, and then maybe that will change here in New Zealand?
Certainly, I
Outside.
see dermatologists doing that privately, and that's certainly what I did. I used to give my patients, I hoped, clinical and health excellence. And so what would I do for myself or my family? I suppose if I had eczema the first time, I'd probably use a steroid. If it came back, I'd be then thinking, well, I don't want to go on putting steroids on my skin for all the reasons I've gone through. I personally see them as very reasonable. The first line is detergent avoidance. Second line is emollients and soap substitutes and quality leave-on emollients. And there are many, many other things I do for eczema besides that. I like to preserve and look after the microbiome, and there's some creams that can support that, like Lipicar balm. And I like anti-inflammatory things like nicotinamide. So there's a lot of other things I'm talking to my patients about, and vitamin D and ultraviolet lights, so many other things that are really important for eczema. But if I'm managing it therapeutically with a steroid or whatever, I'd certainly use one initially, unless it was eczema on particularly vulnerable skin, like around the eyelids. So that little boy of 3, I went straight in with Protopic, I think. He may have used a steroid before, but from somebody else. But when I saw him, it was definite that this skin is so vulnerable, it's so close to the eye. I wanted something that I could feel totally confident wasn't going to damage the skin barrier and wasn't going to cause any immune suppression.
If someone has both acne and eczema on their face, can they use Tacrolimus or Pimecrolimus on their face and a topical retinoid product at the same time? Is that safe?
That's a good question. Safe, perfectly safe. I wouldn't use them both at the same time, the same day, but not at the same hour. The retinoid, of course, is going to be quite irritant to the eczema. That can be really difficult. Fortunately, it's not a common combination because the excess seborrhea in acne makes eczema quite less. And one of the things I do say to my younger patients with eczema, one bit of good news is you're going to get milder acne than otherwise would have been the case. But no, you certainly could, but certainly it's not that the Protopic's doing any harm to the acne, but the topical retinoid is going to be making the eczema a bit drier and more sore and more inflamed generally. So they may find it harder to tolerate the retinoid. I'd want to go in with a particularly gentle retinoid. Do you have Adapalene in New Zealand?
Yes,
Different.
I think it's under different gel brand.
Yeah, different gel, yeah. And the benzoyl peroxide is also quite irritant stuff as well. So those, I build them up very gently, very gradually, and I do incredibly gently in someone who had eczema as well on the face. But Adapalene is the least irritant of the topical retinoids. And it doesn't cause any photosensitivity, unlike the others.
Oh, great. What about in venous eczema, George?
Yep.
Go ahead and use it just like
Yep.
just like we would.
Yep.
Okay, awesome.
It's not lice. It's not atopic eczema.
No.
But I don't recall using it. But I don't see why not. It's an eczematous process. It would switch it off. Well, it hasn't got that abnormal immune pathway going on. And there's so much else to do with venous eczema. There really is. But yeah, I've never used it for acute lipodermatosclerosis. I've only ever used topical steroids for that. It probably wouldn't penetrate down into the deeper dermis, which is where the acute lipodermatosclerosis is causing the inflammation. So I wouldn't use it for that. But I haven't ever used it for venous eczema, but I don't see why at all why you shouldn't.
There's a good question around Elidel or Pimecrolimus in skin cancer, George. So one of our New Zealand groups, MedSafe, says that we shouldn't apply it to areas affected by pre-malignant or potentially malignant skin changes. What would be the reasoning behind this?
Again, I think it's a licensing that's sort of hung over from our original concerns that these drugs systemically can increase that risk. And so, yes, I think people do talk about sort of UV protection and being careful in the individual who's got that increased damaged skin, UV damaged skin, and that increased risk. Were it me, I wouldn't hesitate to use them because I genuinely believe that any risk that they cause, increased risk of skin cancer, is just unmeasurable.
If there's already an area on the skin that looks pre-malignant or potentially malignant, should we avoid these products on that area?
I suppose it would be wise to, wouldn't it? Yes. Yeah. I think that would be a very wise decision. Yeah.
There's some questions coming in
But
around.
also, I wouldn't want to use a steroid there either.
No, that's right. And there's some questions coming in around topical steroids, George. You mentioned often people don't use enough of them or don't use them at all. Occasionally we see kind of, I guess, an over-reliance where people are requesting them all the time and using heaps. How do you kind of manage that if you feel like someone's using too much?
I think I get in and discuss it with them. Why are they doing that? Why aren't we controlling their eczema better? And sort of share with them the damage that steroids can cause. talk to them about fingertip units. I think by overusing them, you don't get more benefit. So the fingertip unit is pretty precise for the benefit you can expect from a topical steroid. So you've got 2 palms for 1 fingertip unit. Using it just once a day like that, you get optimal benefit and least side effects. And I think they're just going to be increasing the risk of side effects. So I'd want to go through that with them, and then maybe put some restrictions on their prescriptions. So maybe they need to come back and see me. I think these are powerful drugs.
George, you talked about the acidity and then alkalinity of the skin and how important that is with eczema. One of the things that we're often taught to recommend in New Zealand is bleach baths, which, you know, given it's alkaline, what are your thoughts on that with eczema?
I absolutely hate bleach baths. I think they
Okay, tell
are
us about that.
utter disaster. Bleach has a pH of at least 11, as hypochlorite. Even diluted, because that's a log scale. Every time you go up from 7 to 8, 8 to 9, you're increasing this concentration tenfold. So if you dilute bleach in a couple of catfuls in a full bath of water, it's still alkaline. And this is going to be napalming your microbiome. I have never recommended a bleach bath. I think they are an utter disaster for the skin barrier. I would steer well clear of them. If you're having recurring problems with flares being triggered by bad bacteria, rather than using hypochlorite, which is Milton, we tend to use Milton in this country, not bleach, but Milton and bleach contain hypochlorite. Rather than using hypochlorite, I prefer to use stabilized aqueous hypochlorous. Do you know about hypochlorous?
No.
It was discovered in the 1834, very unstable, so dismissed. The next time the profession came across it was in the First World War, when soldiers who fell into water or mud after being exposed to chlorine gas, their wounds healed and didn't get infected. For 20 years, they've been stabilizing it in the UK, I think in Oxford actually, and they've now got a stable preparation called, in this country, you can buy it on the internet, called CliniSoothe Skin Purifier. It kills all bacteria, all viruses, fungi, and it's the only agent that kills fungal spores. Brilliant. So you're getting recurrent athlete's foot. It will kill the spores in your shoes and socks and things. You can you can soak your shoes in it to kill the spores so he doesn't get it reinfected. And wait for it. It is 80 times faster acting and quicker and stronger than bleach.
Oh, wow.
It's produced naturally by our neutrophils, mast cells, and eosinophils as part of our innate immune system. So it's totally non-toxic to mammalian cells. No cases of allergy. And it's powerfully anti-itch and anti-inflammatory. I've used it for sunburn, just switches it off in 24 hours. Stinging nettles within a few minutes, insect bites, a few minutes. So I use it for warts and molluscum and impetigo, leg ulcers. Leg ulcers needed dressing twice a week. Soak them in this with the dressing, just change the dressing, leave the dressing, just change the crepe bandage every day, just re-soak it a day with this chemical, and they heal in 2 weeks. It's amazing stuff. Lots of surgeons are now using it to clean the skin prior to operating rather than chlorhexidine or iodine. And it's absolutely brilliant. You can buy it over the counter. I wouldn't cover the skin in it, but I would treat any bad areas. You don't want to napalm the microbiome. You must keep the microbiome healthy, but just treat the small areas and then allow the normal microbiome to grow back over again. Unbelievable. One quick question. What is the concern using Elidel and Tacrolimus in those under 2 years of age? There isn't. It's purely that when they first sought their license, they had evidence of Elidel safety data evidence down to 3 months. I was actually, at that time, I was working with that company, giving them some from primary care advice. And we were seeking a license. We were going to seek a license from 3 months back in 2001. But then when Tacrolimus got its license in Europe from 2, they changed their requirements. And they just did that. They got safety data right down to that age. They're not dangerous. They're perfectly safe. It's just the licensing hasn't been asked. It's like many drugs are safe in pregnancy where we wouldn't ask to use them, so they don't get a license for that. It's not because of any safety concerns. I suppose the skin is thinner and slightly just more cautious with children, but there's no worry. I've used them without hesitation and would use them with my own grandchildren under 2.
Oh, great. Thanks for the extra tidbit, George. That's awesome. All right. Thank you, everyone,
Lovely.
and good night.
Enjoy your evening. I'm going to start enjoying my day.